Welcome to Iswam Visual 2021.
everybody. Welcome back again in 11th Virtual Iswam. Today is the 12th of January 2021, and this is the session 8. This afternoon about topic Dermal Filler, Guidance and Techniques. So we will have two speakers this afternoon. The first speaker will be from Indonesia, that is Dr. Stephen Narmada, plastic surgeon reconstruction from Indonesia. And then the second speaker, we will meet our speaker from Italy, that is Professor Dr. Luca Piovano, PhD. Okay, so we shall greet our first speaker. He is already with us today. Hello, good afternoon, Dr. Stephen Narmada.
Hello, good afternoon, Dr. Santi. How are you?
How are you? I'm fine, thank you.
Yeah,
Hope
also.
you all okay. I hope you are always in a good health and success in your practice. Uh, we would like to say thank you, Dr. Stephen. You have come
Yeah.
to Iswam Virtual, and this session we will talk lots about fillers. And this time
Okay.
you will explain about soft tissue fillers, management of complications. Yeah, this is
Okay.
very important for doctors in aesthetic and anti-aging practice. Yes. So before Dr. Stephen give his presentation, may I read the CV of Dr. Stephen? So Dr. Stephen Narmada, plastic surgeon reconstruction from Indonesia, education, 2000 graduated as medical doctor from University of Indonesia, Jakarta. 2017, plastic reconstructive and aesthetic surgery specialized program from University of Indonesia. For work experience, 2018 until present as the head of plastic surgery division at Hospital of RSAU M. Salamun at Bandung, West Java. And then 2018 until present as doctor plastic surgery in Lineation Clinic in Bandung. Okay,
Okay,
to
thank you.
Dr. Stephen. So now the time is yours. You can start. Okay.
Okay, thank you. I hope all participants in good condition. Okay, today I will talk about filler complication. As practitioner, in addition to being proficient in filler injection, we must also be vigilant and know the treatment for filler complication. Okay, look at this slide. Look at this mass in forehead and lower eyelid. Uh, okay. This mass occurred 2 weeks after the filler injection. Maybe you have see a case like this, and then redness on the nose tip 5 days after injection, and this is a filler migration in radix area 3 weeks after injection. There's so many cases like this. And look at this beautiful lip. We can see the yellow mass at beautiful lower lip after collagen injection, and this a natural look of upper and lower lip after polyacrylamide injection. Okay, this is more serious complication. Redness, pustules, infection, and necrotic skin on nose and forehead area. Okay, hope it never happened to our patient. Let's pray to God. Okay. Okay. Today I will talk about filler complication. Why? There are three factors that influence the filler complication. First is product, second is technique, and patient factor. But most influential is our technique. Okay, let's talk a little bit about the product. There are a list of most common injectable fillers for soft tissue augmentation. Green box is hyaluronic acid filler, which will be absorbed within a few months, and there is an antidote in case you have a complication. And filler in yellow box is calcium hydroxyapatite, and will be absorbed within years, longer than hyaluronic acid. And the red box is a permanent filler. We know the silicone oil or gel today is banned by FDA. Meanwhile, polyacrylamide hydrogel is often used for breast and buttocks filler. Okay, be careful when using filler in yellow and red box. Why? Once you have complication, there's no specific antidote like hyaluronidase. Okay, I will explain a little bit about hyaluronic acid. There are two types of hyaluronic acid. First, monophasic, consists only cross-linked hyaluronic acid. Meanwhile, biphasic consists of cross-linked and non-cross-linked. The non-cross-linked hyaluronic acid will act as a lubricant. It is easier when you inject biphasic filler because it has a lubricant. And then complex modulus, or we said modulus G, is related to its ability to resist deformation when injected, and cohesivity relates to the way the filler flow from needle, therefore its ability to resist the fluid phase of shearing force. Viscosity or cohesivity depends on hyaluronic acid concentration and degree of cross-link. Higher amount of concentration, filler would be long-lasting and hard. And the particle size, small particle is used for dermal layer, and large particle is used for subcutaneous or beneath. Okay, let's look about this slide. I will show you biphasic and monophasic when we dilute with hyaluronic acid. The differentiation between biphasic and monophasic when dilution with hyaluronic acid, you can look 1 cc biphasic filler when diluted with 750 unit hyaluronic acid in 5 minutes will dissolve faster than monophasic filler. This experiment shows us biphasic filler is easier to dilute using hyaluronic acid than monophasic filler. So if you have a nodule or complication with monophasic filler, you need extra massage to dissolve the monophasic filler. Okay, and this is a calcium hydroxyapatite. We know the brand. Calcium hydroxyapatite consists of 30% calcium and 70% water gel. After injection into the body, it stimulates the surrounding tissue over time to promote collagen. In addition to volumizing, it is widely used for the purpose of improving skin texture. And after the gel water absorbed, the calcium phosphate will be absorbed in 70 and 8 weeks. Okay, it's longer than hyaluronic acid. We can see this particle. Okay, this slide show you about experiment gain when the hyaluronic acid combined to the calcium hydroxyapatite. We can see after 24 hours, the calcium hydroxyapatite still in this solid situation. There's no dissolve anything. Okay, and then this is a polyacrylamide gel, consists of 2.5 until 5% in sterile water, soft, pliable, commonly used for breast augmentation, facial, and butt. Polyacrylamide gel is resist to enzymatic degradation, so it will stay longer in your body. Since the particle can harbor bacteria, there's a high risk for infection and abscess. And another complication using this filler are swelling, lump, breast deformity, migration, nodule, respiratory distress, and you must remember, there's no antidote like hyaluronic acid to dissolve this filler. Okay, filler complication when it will be happen. The side effect of filler complication can be categorized according to when they occur, as early or late complication. Okay, early onset occur within 1 until 2 weeks, and the late onset occur more than 2 weeks till 1 year. Okay, I will focus in this filler complication. As you see, this filler complication is many variation from minor like bruising, swelling, erythema, nodule to major complication like blindness, brain infarct caused by vascular obstruction. Okay, we'll talk about bruising and swelling. Bruising and swelling is most common minor complication. It caused by blood vessel rupture and blood stagnation, and will peak around 24 until 48 hours after injection and resolve after. For prevention, you should use fewer puncture site. Fewer puncture site is better. gentle and smooth needle movement, and inject at avascular layer like supraperiosteum. And for prevention or treatment, you can do ice compression before and after injection, and then LED phototherapy and ointment like vitamin K ointment. And second is erythema. Usually, temporary erythema will be will be able in 10 minutes after injection, and it's normal. But you must be careful if your injection site has a little skin redundancy and previous fibrotic scar. When erythema persists more than 24 hours, maybe there are minor vessel compression. So for prevention, you have to know the previous operation like rhinoplasty or maybe operation before or filler before, and don't inject too much at the area of little skin redundancy, and be careful of blanching after injection. You may obstruct the vessel, and then you must avoid polymethyl methacrylate and calcium hydroxyapatite in that condition. And for treatment, decompression using hyaluronic acid if you are using hyaluronic acid filler. But if you're using calcium hydroxyapatite or another type of filler, you have to immediate evacuation by puncture of negative suction. Okay, this is you can see in our face there are a lot of vascular network, and it is impossible not to inject or not to harm the vascular. Okay, there are two mechanisms to obstruct the vascular. First is embolism, when your needle get inside the vascular lumen and filler being injected with high pressure. Second, vascular compression. This is the common cause of vascular obstruction. Okay, I will talk about skin necrosis because there's many cases. Skin necrosis, if the injected filler mass is pressed against adjacent artery, ischemia may progress slowly and skin necrosis may occur. When the filler mass compress a vein, venous congestion can be occur, and this lead to the oxygen supply from the arteries decrease. This can eventually cause skin necrosis, progress slowly. And this usually happen when inject filler at superficial dermis because it tight and compact. Okay, what the risk of skin necrosis? The risk is more superficial filler injection because the dermis is tight. Thicker, harder, and tighter skin, like area on tip nose, you must have to be careful. A large filler amount at one side can compress the vascular, and a small needle diameter have a higher risk of embolism. You have to be careful if you're using a needle and small. And you have to be very careful because in high vascular region, you have to use cannula. Okay. There are factors that contribute skin necrosis. First, the degree of blockade blood vessel. The area of skin necrosis caused by intravascular embolus is much larger than the area caused by extravascular compression. Second, the diameter of blood vessel. If there are total obstruction, is more severe than partial obstruction. And third is anastomosis with adjacent artery. More anastomosis, the skin will have faster recovery. Okay, you can see in this slide, large plexus obstruction will cause extended necrosis. In 2 days, there will be a branching pattern and spreading redness compared to small plexus injury. This condition will lead to skin necrosis, infection, and pustule formation. Okay, this picture shows us about symptoms and treatment depending on the timing of necrosis. When you have impending necrosis, it is a ischemic state. The symptoms is a reticular pattern, purple color, pain, and swelling. What you can do, First is decompression. If you have ischemic state, you can use hyaluronidase, and then puncture and drainage if you using another filler than hyaluronic acid, like calcium hydroxyapatite. If there's a blanching, you have to drainage or puncture as soon as possible. And then you can do warm massage, revascularization, and using vasodilator like xylostazol or asprotidil. And you can do hyperbaric oxygen and aspirin oral medication. And when you have skin necrosis, like infection and wound healing state, you will have a symptom like pustule and eschar. So you have to do infection control by giving oral antibiotic like clarithromycin or quinolone like ciprofloxacin for 7 until 10 days. And the important thing, you must remove the pustule. You can see the pustule. You have to remove gentle, and after you remove the pustule, you have to apply the dressing. The principle is moist gauze. You can use anything like gel or water salve. I use chloramphenicol eye ointment usually, and then maybe you can use PRP or another growth factor in skin necrosis. After the necrotic area is clean, okay, and the scar formation, it means you have a skin defect. The symptoms is redness and depressed scar. For scar treatment, you can do vascular laser, fractional laser, or for plastic surgeon, maybe can do skin flap or skin graft if the defect is large. Okay, I want to tell you about infection. There are two types of infection. If erythema persists more than 48 hours after inject, and the infection occur before 70 and 2 hours, the cause of infection is microcirculation problem. Why? Because the skin barrier is lost and normal bacteria will infect the skin. So you can see the pustule. Okay, but if infection occur without persistent erythema, there's no history of blanching or erythema, and after 3 until 7 days, it's likely to be general infection. It means there's a bacterial contamination. Okay, there's no microcirculation problem. What is the difference? The difference is if the infection occur more before 3 days, you can do hyaluronidase. So it will increase the microcirculation. Okay, this is a picture about wound healing skin necrotic. You can see the picture. There's 4 days after injection, there are necrotic skin, and this condition there's no benefit inject hyaluronidase because they're already necrotic. So what we can do gentle or minimal debridement, not extensive debridement, and then we use occlusive dressing to the wound. We can see the after 30 days after injection, there are redness and depressed scar. So we can do like microneedling or PRP to improve the quality of the scar. But don't do extensive debridement because we must maintain the skin framework for wound healing. Okay, and then I will talk about visual complication of filler. Although this is still small incidents, but you have to be careful because this is a fatal complication of filler injection. Filler injection into the supratrochlear, supraorbital, or dorsal nasal artery cause ocular complication via regurgitation into the ophthalmic artery. If the filler that you inject is higher pressure than arterial pressure. And when any ophthalmic artery branch becomes occlude, the visual complication will occur. And if it arises to internal carotid artery, it will cause brain infarct, like stroke symptoms. You can see this is the area that you have to be careful. Nose, labella, forehead is the common site of filler embolism to ophthalmic artery. Be careful when you inject to that area. Hope you can use cannula, low pressure when you inject. You can do like microdroplet and retrograde injection. You can see the route of supratrochlear artery, dorsal nasal artery, and supraorbital artery to ophthalmic artery. When you inject and there's embolism with high pressure, so the filler can go to the ophthalmic artery and make the retina break. But when it just compress the circuit of the artery, not embolus, maybe you can find only skin necrosis. There's no blindness, there's no a symptom of stroke. Then okay, the symptoms are that you have to be careful is sudden severe pain is the most common of symptom, and blindness, blur vision, hemianopsia, decreased visual acuity or visus, and sometimes patient complain blepharoptosis. You can elevate the eyelid, and skin necrotic, and sign of brain infarct like stroke. So you can smile, smile will go to just to one side, and you have to check about the power of motoric hand or leg. Okay, this slide is important, I think. This is a retrobulbar hyaluronic acid injection. Okay, once the patient have the complaint like blindness and sudden severe pain, you must remember this treatment because time is a vision. You can use Timol to reduce ocular pressure, and you can do ocular massage, just gentle ocular massage to recanalize vessel by pressure difference, and acetazolamide to decrease the ocular pressure and increase the retinal perfusion. Okay, look carefully to this picture. Retrobulbar hyaluronidase, not all doctors are familiar with this technique. But if this method can cure the complication, I think it should be performed. You can use 18 gauge or long cannula. It's also acceptable. The entry point is you can see the lateral canthus, and you feel the bone. Okay, the entry point should be the lateral part of the orbital rim, and you have to scratch the needle tip to approach the retrobulbar space. It's about minimum 25 until 35 millimeter, and then you have to inject the hyaluronidase 150 unit and repeat after the symptoms is resolved. Okay, I think that's not very difficult, but you have to remember because your panic condition and you just send to the hospital, or you have just make the patient wait, I think the visual will cannot come back. Okay, this another complication is lump, infection, nodule, and granuloma. That's what I say before. One of the main cause of filler complication is the technique used by the operator. This is important. You have to do asepsis and antisepsin and use sterile hand scoon. Because this important thing the operator must do correctly, and don't underestimate the bacteria around you. We don't know if your hand or your hand scoon is sterile or not, because once you have complication, it will a prolonged state for recovery. Okay, this the basic concept when you inject the filler. If you want to inject at superficial layer, please use soft gel, small particle, and small amount. This is for stretching the dermis, and you can use firm gel, large particle, and large amount in a deep plane to give volume and strengthening the structure. This picture shows us about average skin thickness of your face, you have to be careful when inject the firm gel with large particle and large amount in thin skin area, like periorbital, because the patient can palpate and see the lump. For forehead area, periorbital and perioral area, you can use a low viscosity filler, but for contouring the nose, chin, jawline, or bone structure, you have to use medium and high viscosity. Don't use a large particle in superficial area in periorbital because it maybe just a few days until weeks, the patient will palpate the nodule. Okay, you can see the different level of the cannula when you do deep and superficial injection. The left side is deep and the right side is superficial. So if you want to make it certain you're in deep or superficial, you can do like this picture. Okay, why filler often migrated to nasal root? Okay, you can see this is a before after. Okay, nose have 5 layer: skin, superficial fatty layer, fibromuscular layer, and deep fatty layer, and the periosteum. In tip nose, the layer is thick, firm, and adherent, but in the nasal area, the layer is loose and mobile. That's why when you inject too much filler, it will easily migrate it to the paranasal area. And you can see this. The tip is thick and the nasal area is mobile area. So this is another important thing that you have to know, the patient immunologic state. For patient with menstrual period, common cold, highly stressed state, and depressed immunologic state can relate to filler nodule. Maybe the immunologic status correlate to hypersensitivity and allergic reaction. Also, you have here about the vaccine that can induce facial inflammation. Okay, I will talk about filler. Nodule filler induce hypersensitivity. Nodule filler can induce hypersensitivity reaction type 4 or delayed type. Bacterial protein endotoxin will act as antigen from filler and will be recognized by macrophage. And after 2 until 3 weeks, lymphocyte T will provoke inflammatory reaction. This is very important because there's maybe some connection why vaccine will can make the inflammation or filler induce hypersensitivity. And when inflammation become chronic, there will be a thicker capsule and multi-giant cell surrounded the antigen. We call it granuloma. Okay, you can see this slide. There's a hot news. There's many vaccine, Moderna, Pfizer, Sinovac, you hear, but in this news, Moderna vaccine causes swelling and inflammation in patients who have cosmetic filler. There's still no detailed explanation about this, but some experts believe that immunologic patient after vaccine will react to foreign body and make allergic reaction. You can see this slide. I have searched about this. Maybe this slide could explain when RNA messenger vaccine enters to your cell and tells them to produce coronavirus spike protein. This will provoke your immune system to produce antibody and activate lymphocyte T. Lymphocyte T is important to destroy the infected cell. So filler is antigen, and this mechanism will react to lymphocyte T that induced by vaccine and can induce hypersensitivity reaction to the filler. But we don't know clearly about the incident, what type of filler, and the exact mechanism. But until now, there's no report using Pfizer or Sinovac that can induce the inflammation, filler facial inflammation. But you have to be careful because Pfizer and Moderna is the same mechanism. that's two vaccine use mRNA vaccine. Okay, this picture show us about you can see before after filler and 12 day after filler there's no complication at all, but 14 days after injection there was a nodule on left cheek and subside at 18 days, and after that repeated swelling at 25 and 71 days post injection. This is characteristic of filler nodule. Sometimes it will be rise, sometimes will be subside. Actually, when you give steroid or oral antihistamine, it will subside. Okay, there's another case. 10 days after injection, there you can see before and after. After is good condition, but 10 days after injection, there was a nodule at left tear through, and after hyaluronic acid injection, the swelling is subside. But you have to you have to evacuate, or you have to give hyaluronic acid to dissolve all hyaluronic acid, because if still a small particle, it can be induce the nodule again. So how to differentiate the mass? Is it lump or just swelling, or infection or filler induced hypersensitivity? For lump, usually acute, palpable after injection. In swelling, still immediate, but you can palpate the contour and continuous pattern. For infection, usually occur before 7 days after injection. You can feel acute inflammation, pain, and patient complain about pain and tenderness. But this is different from filler-induced hypersensitivity, nodule or granuloma. Usually, after 14 days after injection, the patient can palpate the mass, hard nodule, and related to immune status. Okay, so how to treat the nodule? We can treat a nodule with a steroid drug combined with antibiotic for 7 until 10 days. But if it doesn't subside, hyaluronic acid can be injected to the nodule. Hyaluronic acid work for hyaluronic acid filler only. We can do negative suction or puncture if patient have calcium hydroxyapatite or polyacrylamide, but it can be done before 2 weeks. Why? After 2 weeks, the calcium hydroxyapatite will become hard and solid. So there's no use suction or puncture. It cannot be worked. And you can do also steroid injection combined with anti-emetic agent. I think this very powerful. I usually use this combination 5-fluorouracil 7 to 3 triamcinolone for fibrotic nodule. So it will make the fibrotic small. Okay. This is the technique for injection. When injected, when you inject the hyaluronic acid outside the mass, the hyaluronic acid cannot pass through the fibrotic capsule. So the hyaluronic acid must be injected in the center of the mass. If you write, you need higher injection force, and the mass will increase immediately. So you do a right technique. And then when you inject it to nose area, there are multiple layers. Okay. So if you're not accurately inject the hyaluronic acid to the nodule, it will not break the nodule. So patient will still complain about the nodule. So you must massage after injection to make the filler hyaluronic acid spread accurately. Okay, this is the slide. There are nodule like hump in keystone area. Patient complain after 3 months after injection. So I do open rhinoplasty to evacuate the filler, and then I continue with diplasty using ear cartilage and silicone implant. So this is a simultaneous simultaneous treatment for the patient, evacuate the filler, and then doing operanoplasty. But if there's a infected condition, the operanoplasty or using the implant must postpone until 6 and 12 months. And then this is a hydroxyapatite filler during operanoplasty. You can see when I remove all the calcium hydroxyapatite, there's a solid mass. So in this condition, hyaluronidase or continuous suction cannot be done with this condition. Okay, this is for siliconoma. Siliconoma actually is a filler, is permanent filler, and then that I said this banned nowadays by FDA. You can see the type of the nose, and what I do operanoplasty, and then I excision one by one, and still maintain the structure of nose, and I do ear cartilage graft for T-plasty. There's a photo before and after. And negative suction. This negative suction, usually like small liposuction, you can do filler evacuation, usually if you injected the calcium hydroxyapatite. But you have to do this negative suction before 2 weeks, because after 2 weeks it will be a solid particle. So I will puncture in 2 sides and then do suction. You can see the filler, and then this multiple nodule after breast filler using polyacrylamide. Yeah. The patient complains about multiple nodule, and I do MRI to see where's exactly the position of the nodule, and then this picture show that the filler was migrated under pectoralis major, in glandular area, and rectus abdominis. Why? Because breast usually squeeze. Okay, when the breast squeeze, you have to realize that the filler will disperse to side, so it will be migration. It will migrate. Okay, what I do is I do inflammatory incision of filler and filler evacuation. After filler evacuation, I implant the microtexture implant with dual plane pocket. This is a before and after condition. And how about autologous filler, or we say fat graft? This patient before and after fat graft, 30 cc micro and nano fat graft. I do in forehead area, temple area, periorbital area, smile line. You can see before and after 4 months. I inject 30 cc because fat graft usually will persist about 60 until 65%. So and I inject more because after 4 until 6 months it will reduce. And this also fat graft before and after. I inject 18 cc micro and nano fat graft in temple, forehead, in zygomatic area. You can see before and after in zygomatic area. And how about the complication? Actually, the complication is similar. It will be bruising, udem, infection if there's contamination, calcification or oil kiss. But the risk of embolism may be more lower because using large cannula, and I use usually MAF gun. MAF gun is some kind of tool that you can inject the fat graft with 1 cc. You can shoot 100 times if you use 1 cc fat graft. So because of the micro droplet, the risk of embolism is very low. And then the most important thing is less allergic and hypersensitive reaction if we compare to the filler. So for conclusion, in order to prevent this side complication, it is essential to understand and the properties of filler, precaution for various injection methods, and facial anatomy. This slide is, you can see this conclusion for my presentation today. Yeah, bruising, you can use ice compression, erythema, infection, skin necrotic. You can see detail this slide. Okay, thank you for the attention.
Okay, thank you very much, Dr. Stephen, for very important explanation, yeah, about side effect of filler, how to deal if we have complications with fillers. So all doctor participants, please, if you want to give questions to Dr. Stephen, please write down your questions in question box, and then we will discuss with Dr. Stephen. We already get a question here. This is from Dr. Tias. Can we still do hyaluronidase, the filler, after we did the filler in a few months in patients' face? What do you think, Dr. Stephen?
Yes, we can still the hyaluronidase filler.
Mhm,
Why the filler still not dissolve and patient complain about nodule? Because
mhm,
when the filler is surrounded by fibrotic tissue, the filler cannot dissolve because usually our body have a hyaluronidase. But if uh, there's a fibrotic capsule like granuloma, you can still inject to the center of the mass to dissolve the filler using HDS.
Okay, yeah. Is that in one-time procedure or after we do it hyaluronidase, then we have to control maybe in a few weeks and then we see how the result.
Yes.
Okay, yeah. Again, to all participants who want to give questions, please write down your questions in the question box. Okay, Dr. Stephen, you mentioned about if vaccine can also, because now it's in a pandemic condition and everybody someday in the several years we will get vaccines, and if somebody get vaccines and then maybe it cause swelling or inflammation, so we as the doctor, GP doctor in aesthetic clinic, uh, what should we do if we
Okay.
get patients with that condition?
Okay. First, before you do the filler injection, you have to inform consent about the situation.
Hmm.
This absolutely you have to do inform consent. And if the inflammation filler, you just give a steroid oral or antihistamine oral, and
Okay.
usually will resolve in 1 or 2 days.
Okay.
But because there's still no guideline about filler and vaccine, I think we have to wait about the more what, experiment. So
Yes.
I think you have to postpone the filler, or at least you have to give informed consent to your patient.
Okay, yeah, yeah. If somebody had plan for filler and want to do vaccines, maybe it will be better to, yeah, pending the filler first. Yeah, but if if we have given the steroids and antihistamine and the result still, the inflammation still remains, what do we do? Shall we refer to plastic surgeons, maybe considering to remove the filler, or what do you suggest if in this condition?
Yes, if the inflammation is still after
Remains,
you
yeah.
give, yes, it's remain and bigger,
Mm.
actually you have to do give to plastic surgeon to evacuate the filler,
Yes,
or you have can do hyaluronidase injection to the site.
hyaluronidase
Yeah.
injection. Yeah. Okay. Yeah, Dr. Stephen, you mentioned lots about danger area. Yeah, that we have to notice if we want to do filler. Could you please maybe once again explain what area that we should notice if we want to do filler, maybe in the nose area or the eye area, that we can get complications? Could you please explain one again? Once again.
Yeah. You know that in your face area in supratrochlear,
Mhm.
supraorbital, and nose dorsal artery or facial artery, the diameter of the vessel is quite big. So
Yes.
you have to really be careful. My you have to using a cannula. Usually I use cannula more than 18G. 18G. Usually 20 is safe. And when you do injection, maybe first you have to aspirate, and then the pattern is retrograde injection, or you
Okay.
can do micro droplet.
Micro droplet.
Yeah.
Okay. Yeah. Okay. Thank you. Now we've already got another questions. Wait, which one? Sorry. Yeah. Oh, for silicone, can I treat? The doctor asked if someone already got silicone injection, can I treat the area with steroid injection? What do you think, Dr. Stephen?
No, there's steroid injection cannot resolve the silicone granuloma, because
Mm,
if you see the histopathology, the fibrotic capsule very thick. So
mm.
for silicone complication like siliconoma, the treatment just operation. We have to excise the silicone granuloma.
Okay, so the only treatment is with surgery, yeah, for the siliconoma. Okay, we've got another questions. Is there any limitation for the age to have the filler injection? Limitation for the age?
No, no, there's no limitation of age. Some of your patient, I have 78 patient, it is okay.
Mhm. Okay, yeah. Uh, okay, I mean, oh yeah, this is yeah. I mean, from what age to can be given filler injection? Okay, so this doctor, maybe she would like you to give guidance in which age that is needed to be given filler. Probably when the aging signs come, and the solution is filler is the indication that we have to give for the patients.
Actually, there's no
There's
a
no
limit of
limitation, right?
age, no limit of age.
It depends on the problem. Yeah.
Yeah, the problem. I have
Okay.
patient with 18, but the
Mm-hmm.
problem is in this periorbital area is dark, and
Mm-hmm.
I have inject the fillers. Okay.
Okay, yeah. So, still about this question, yeah. Most of Asian people, like we are in Indonesia, most of the women usually they complain about the nose because we have rather flat nose, and the girls who is in age by maybe 20 or less than 20, they want to get their nose to be filler. What do you think if we give filler for the young woman before 20 for the nose area?
Before 20, I think maybe if the patient really know what will do with his body is okay. But I think if the age is too young, maybe you have to talk to the parents, their
Okay,
parents.
okay, yeah, okay. So you suggest nose filler to be done after, yeah, after 20,
Yeah,
and not too early.
not really. And
Not
you
too
have
early.
to give informed consent about the filler, because there's so
Mm-hmm.
many filler complication right now, like migrated to in a nation area or redness, or there's still so many
Okay.
complication in filler.
Okay, yeah. Now we've got a question from Dr. Tias. You mentioned about hyperbaric therapy.
Yeah.
In which hospital that we can get this therapy about hyperbaric?
Usually, clinic is a clinic have a hyperbaric therapy. Hospital, I think in Jakarta, RSAL Minto Harjo have a hyperbaric therapy.
Also in Surabaya, we have the RSAL in Surabaya,
No,
and
no,
I think,
in Jakarta also.
oh
Yeah,
yeah,
in Surabaya
Jakarta,
also.
in Surabaya also have
Yeah,
hyperbaric. Okay,
yeah.
okay, already been yeah explained. And then another questions now from Dr. Christina Lim. How long we can give new filler injections again after the complication solved? So she means after the patients get complication and have been solved, and then the patients wants to do another filler. How long do we plan?
Okay.
Uh,
it depends on the complication. If the complication is infection, scar, you have to wait until 6 months until 12 months. If the complication is uh, infection or necrotic scar, you have to do longer. But if the infection just tindal effect after you inject the hyaluronidazole or just allergic reaction, you can do after 6 weeks.
After a few weeks. Okay. And then we've got another questions now from Dr. Maya Safira. Hi doc, what do you think about breast filler using HA, hyaluronic acid for breast filler? Please,
Uh,
Dr.
act-
Stephen.
yeah, actually, using hyaluronic acid, you have to get a lot of CC if you're using hyaluronic acid. Usually, doctor using polyacrylamide gel because it's more cheaper. And but as a plastic surgeon, I don't recommend breast filler because there's still many complication. Most complication is migration. You can
Okay.
ask your patient after a few weeks after the breast squeeze by her husband, the filler will migrate, and then the incidence of nodule is quite high. So be careful if you inject the breast filler. And there's a case embolism in I hear Indonesia case Indonesia embolism, and if filler is injected to the vessel, it will will be acute respiratory distress syndrome and patient die. So you have to
Okay.
really be careful.
It's okay. Up till now, breast implantations by surgery is the best choice. Yeah, Dr.
Yeah,
Stephen. Yeah.
yeah.
Okay. Uh, we we get another questions now is from Dr. Tias again. How can we determine if the filler goes into orbital rim regarding filling tear trough? So yeah, tear trough is many doctors do tear trough because this is most problem from patients. Yeah, how
Yeah.
do we determine if there's a problem with this? Okay,
Actually, you can palpate when you inject. You can feel the needle touch the bone.
that's the bone.
I usually when inject the filler to tear through, I have to what technique. I usually inject in the supraperiosteal or in the muscle. But if you want to do inject in the superficial layer, you can do when you inject the cannula, and you can dissect it slowly and inject the small filler. So, but if you want to avoid the complication, it's better to save inject in the supraperiosteal layer. So you just inject and feel the bone. The cannula touch the bone, and you can inject it in retrograde patient.
Okay, yeah. So, which one do you prefer, Dr. Stephen, if we are doing the tear trough area using the cannula or sharp needle?
I usually using cannula.
Cannula prefer.
Yeah.
Okay, yeah. Okay, so we'll see. That's how we determine. Okay, that's what I meant then. Okay, there's no other questions. Okay, to all participants, is there any doctor who wants to give questions to Dr. Stephen? Yeah, yeah. Okay, we have already got so many to discuss about complications. Yeah, maybe Dr. Stephen, you want to give some conclusion or some take-home message that every doctor who wants to do filler have to notice to remind in our practice. Please, Dr.
Okay.
Stephen.
Okay. For a beginner, please don't using filler like calcium hydroxyapatite and polyethylamide for beginner, because once if you have complication, that's really hard to solve it. For beginner, you have to use only hyaluronic acid. And if you do inject hyaluronic acid filler, you must have the hyaluronidazole, not just one vial, but you have at least 5 until 6 vial, because if there's embolism, if there's a vascular compromise, you need more than 5 vial.
Mhm.
and you have to know exactly about the face anatomy, and uh, better use cannula than sharp needle.
Okay. Yes. Thank you, Dr. Stephen.
Yeah.
Okay. Some doctors still give questions. Maybe we still have time to discuss about this. How was the main about this is about preventing the bruising. Dr. Stephen said that you can use LED. We use it before or after treatment. So please give guidance how we use the LED to
Okay.
prevent the bruising.
Okay. I mean the LED after treatment. If you have bruising, you can use LED. But if you want to prevent bruising, what you can do, you have to compress the ice pack before treatment to make it vasoconstriction. After 15 minutes compress, you can do injected slowly. And after injected, you can do compress ice pack again. LED treatment just for after if
After,
the
yeah.
bruising exists.
Okay. And what color do we use about the LED? If we use the LED?
Uh, Colors maybe I usually not expert in using LED
Mm-mm.
because and I cannot give a question answer.
Okay, yeah. Okay, depends on the machine of LED,
Yeah.
yeah. Okay, I hope that answered the questions, yeah. I think we're running out of time, yeah. Thank you very much, Dr. Stephen
Okay. Thank
Namada. We
you.
have discussed lots of things about dermal filler, and we aware to prevent the complications, and we know what to do for the first aid if there is complication when we do filler.
Yeah.
Okay, thank you very much. Hope
Thank you.
everybody enjoy and we have something to learn today. Okay, thank you very much, Dr. Stephen.
Thank you, Dr.
Stay
Santi.
safe, stay healthy, and success always for Dr. Stephen.
Okay. Thank
Okay.
you.
Yeah.
Thank you so much.
Okay, thank you, everybody. This is the end of the session. The first speaker is from Indonesia, Dr. Stephen, and after this, we will have the next speaker is from Italy, Professor Luca. But we will see what is in our screen now. Okay, see you after this. Okay, everybody, we're back again. We're still in the eighth session of virtual Iswam today, and our topic this afternoon is still about dermal filler, about guidance and techniques. And this last session of filler, Professor Luca Piovano, PhD from Italy, will talk about fillers LP injection mode. So now for our speaker already here with us, let's welcome our speaker. Hello. Good afternoon, Professor Luca Piovano.
Good afternoon, Santi. How are you?
Yeah, I'm fine. Thank you. And how are you, Professor Luca
Fine,
there?
fine. Today Rome is
Okay.
very cold. It's 0 degree. Zero. It's
Oh, I
very, very
see.
cold
I
today.
see. I see. Yeah, but Professor Luca, you always look handsome, and thank you for being here, sharing your knowledge with us. Yeah, in Indonesia now it's rainy time. Okay.
Sorry.
Yeah. Okay. So before Professor Luca give his presentation, let me brief. Let me read briefly her CV. His CV. Okay. Professor Dr. Luca Piovano, PhD from Italy, medical education 1981-1988, medical degree from First University of Rome, La Sapienza Medical School, graduated with with honor. And then 2006, Manhattan Eye, Ear and Throat Hospital advanced in aesthetic plastic surgery. Okay, and then 2001, Pontificia Universidad Católica of Rio de Janeiro, and then 1999, 2001, Clínica Médica José Hermílio Curado, MD, São Paulo, Brazil, and still so many postgraduate medical education. So now it's time for Professor Luca Piovano to give your presentation. The time is yours, Professor Luca.
Okay, thank you for the nice presentation. And here, this is the presentation from my sister in Italy.
Asal dari Indonesia, di Pulau Flores. Saya bekerja di Roma bersama Dr. Piovano. Pada sore hari ini, Dr. Piovano mau presentasi internasional Iswam online, di mana dokter akan menjelaskan teknik injeksi yang baik dan benar di filler Dr. Piovano.
Okay, thank you so much. It's a beautiful presentation, and now let's start the game. Thank you, bye.
So, from Indonesian sister in Italy, we work together in a hospital. And I will speak today, share with you my experience in filler in the last 20 years. That is my disclosure. I work with many companies, starting from Sinclair Pharma to Merz Aesthetic. So I was lucky because I have to try a lot of product, a lot of syringe, a lot of filtration due to this collaboration. But now today, this presentation is based on personal experience during the last 20 years. It's not commercial, but is to be educational. And in the last 10 years, from December 2010, 10 years, I treated almost 5,000 patients with filler, 20% men, 80% women. The patient ethnicity is all over the world. I travel a lot, mostly from Italy, 50%, but I have inject Egyptian, English, Indonesian, Polish, and every country. And if you look this, the area that usually in Europe we treat with filler, and mostly more than 50% of area is located in the lower third of the face, and we inject 2 cheekbone, malar, zygomatic, and nose. But in Italy, in Europe, this kind of infiltration is less by less. So the most infiltration are on the lips, nasolabial fold, premaxilla, marionette lines, mandibular and pre-jowl sulcus line. And for that, I focalize a book on this technique. The book are 2. That is the first book that I present at INCAS last year, and is focalized on the lower third of face injection. And now it's coming soon the upper third, the nose and the eyebrow correction to the next volume is pending. But move to Asian subcontinents. ASEAN is very huge country, is heterogeneous group. Therefore, we have not uniform population because in Asia we treat a Middle East patient from Jordan. This lady, beautiful lady, is completely different from Indian subcontinent, or is beauty too, but it's completely different. The aesthetic issue. And finally, in East Asia, is different face, this different shape. So it's different. It's difficult to standardize filler injection for Asian subcontinent. And also the East Asian beauty is so variable. We start from oval shape, we have V shape, we have V shape, oval, triangular shape. So a lot of different shape of the face in East Asian beauty. And it's interesting, this paper was published in 2000, just this month, it's a few weeks ago, from Wolfgang Wu, is about an ideal facial beauty among the Chinese population. And from this paper, we make in evidence that the 40% of patients from China like the oval shape, the 25% like the V shape, and then there is so on oblong face, rectangle face, round shape, diamond face, pear, and square. So very different facial beauty among the Chinese population. Why Chinese? Because the Chinese is the most useful. They use a lot of aesthetic medicine now in the world. And but go back to the ethnicity. We see different ethnicity: Asiatic, Indian, and Hispanic. And the beauty, I think, is in the middle. In the middle, from black to blonde lady, there is a hybrid baby, and we see a lot of this kind of hybrid company. This is Italian doctor, is gynecologist, and his wife from Africa. So the baby is different color, different shape, different beauty. And again, from America, different is mixing hybrid family. So I think that the beauty is right in the middle. From European and East Asian beauty, the beauty is in the middle. Look, this is Italian doctor, and his wife is from China, and the baby is beautiful baby with both characteristic, mother and father. But anyway, if you want to conclude the Asiatic main issue, what is this? They ask a lot of change of shape, the occidentalization of his face, and another request from Asia is the nose redefinition, nose reshaping. When I travel to Asia, I do a lot of nose reshaping and correction in volume. And then we have this lady from Papua. Its characteristics, she has loss of volume in the middle third. So there is a lot of request of fullness of malar zygomatic arc. And finally, another correction that I find a lot in Asia is this, the chin and jawline redefinition with a deficit of mental tubercle in this lady. So the augmentation of the chin, because this area is very huge, big, and we have poor representation of the lower third. So that is, I think, the three main issue in Asiatic patient. But if you want to make comparison from Caucasian and Asian, we see that a European narrowing face, white face, completely different. Malar hypertrophy, malar hypertrophy is oval shape, jawline, more oval, dark skin, and finally baby face, aging face. Due to the skin aging, photoaging is very important in Europe, the photoaging of the skin. And the difference from Asia start from a structural facial anatomy, slow rate of aging, seeking treatment at younger age, optimization of Asian feature. Most common of cosmetic surgery, finally, in East Asia are rhinoplasty, blepharoplasty, and lipofilling. That is the three most important in Asia. In Italy, it's different. We have rhinoplasty, but we have a lot of liposuction and breast augmentation. It's different. And the most common aesthetic issue treatment in Asia are injectable and skin quality. Injectable and skin quality. In Italy, in Europe, we do a lot of botulinum toxin procedures, and we do a lot of lip enlargement and the jawline redefinition to correct the ptosis of the face. And that is the most, the structural difference from Asian to Caucasian, different structural basis of scalp. And also from female and male, the difference of skull in African, Asian, European, and male, African, Asian, European. So finally, to conclude, it is impossible to understand, to evaluate patient motivation and expectation without understanding the patient aesthetic ethnic characteristic. So it's very interesting to study ethnic characteristic before and then to go on the correction. An example, the charming role. ISL have an hypertrophy of lower eyelid or lower albicularis muscle. And in Italy, this is considered an aesthetic appearance, but in East Asia is considered fashionable and sign of beauty and youthness among East Asian. So that is the difference, mostly. It's interesting, this paper coming out from a consensus on changing trends, attitudes, and concept is published 3 years ago, 4 years ago in Aesthetic Plastic Surgery from a group of doctors from Indonesia, from Korea, Japan, India, a lot of doctors of East Asia. And finally, they do the consensus about the patient group, what they ask for the correction mostly. And I start to speak about my techniques. My techniques is all in this book, the lower third filler techniques, LP techniques. The content of the books are divided in 4 chapters. Every area of the face is divided in area. And then in one area, I speak about the overview of the district, from the anatomy to the function to the physiology of this area. Then what is the best anesthesia for this area? What is recommended for a perfect satisfaction of treatment and patient? And then I focalize the different implantation technique, how to maximize the aesthetic result with less product. Because my philosophy is this: less is more. I don't use a lot of product. I use just the right product to have my correction without complication. So my philosophy that I write in the book is less is more. And finally, I speak about tip and tricks, tip to avoid complication or to avoid a natural result. So the goal is a gentle lift of facial feature, restoration, natural, curved, depression to enhance the face. For that, I use the right dermal filler, the exact indication technique, and why not? Mostly I use the combination of treatment. I don't use only filler, but I use filler plus botulinum toxin in combination. I use filler plus threads, like we see last day with Dr. Figu, the application of threads, volumization in combination. And the goal is to have a gentle lift, to have linearity, lifting action, like this is called liquid face lifting. This liquid face lifting consists in injectable botulinum toxin filler and to have a lifting effect. What kind of filler I use? As I told you, I work with many companies, so I try a lot of products, different HA, from the old to the new one, filler but HA based. I use filler based on PCL, polycaprolactone. Polycaprolactone is long-lasting filler, is a synthetic product, is aliphatic product that stay in the tissue for more time and give me a good tightening and long-lasting result. I use a lot of calcium hydroxyapatite. It's a very good product, a safe product. I use from more than 20 years. It's good and it works a lot, especially in men, especially when we have the skin so thick. And then carboxymidine cellulosa is another good filler with long lasting. I use whenever the hyaluronic acid is not long lasting, so I change the filler for that. Finally, at least in the mouth area, I use HA, only HA filler. I don't use this kind of filler. This kind of filler I preserve only for the temporal phase, middle third, and the lower third. In the lower third of the face, in the jawline, PCL and calcium hydroxyapatite filler is my favorite. Why? Because they are not heavy, but they are so elastic, so viscous. I have a very good lifting action of the jawline. And finally, least but not the least, at least, is the periocular area. That is very tricky area. I never use filler for this area. The teardrop, the nasojugal sulcus, I use mostly lipofilling. Why? Because the eyes is circumvented from fat, and so I put fat to restore, to vitalize this kind of area. So look, this face is tired face, ptosis face with the uniformity of the face. It's typical aging process in Italian European lady. And we have three main ligaments, retained ligaments. What I do to correct this, I feel in the pre-jowl, post-jowl, to have a lifting action all over the face after the volumization of the malar area. That is the malar area volumization in green. And the volumization of the malar area is moderate. I don't like this Topo Gigio face, Mickey Mouse. I don't like it's too much evident for European style, this correction. Where we inject all over the layer. Usually I never inject the muscle, I don't like. I inject the dermis, the subdermal fat pad, deep fat pad, the over the bone. Depends from the correction that I need. The injection technique is various from the area, from linear threading, fanning technique, bolus technique, pyramidal technique, different technique. Pyramidal technique, I usually inject in the bone, in this area, in the chin, in the mandible, in the zygomatic arc, the frontal bone. I inject in the bone because I want to enhance the bone deficit. When I inject over the under the skin, usually I use this kind of cannula. It's a subtle, easy guide. It's very simple cannula. To have a simple with only 2 insertion points, I cover all over the face, and the spread of HA is fantastic. I cover all over the face just with 2 vials per side. So finally, the difference from needle and cannula, I use both. From needle, I will be more precise. With cannula, less precise. I need more product to get my result. With needle, I have high risk of ecchymosis. And with cannula, I have low risk of ecchymosis, very easy injection, but I have to inject only in parallel way, subcutaneous. With needle, I will be multidirectional, so the injection will be more sophisticated. It's painful, no painful with cannula. So, but if you want to learn more, you can see this paper from Dr. Surek. It's the safe way using cannula in the face. Usually, my approach is this with 25, 23 gauge cannula, 1 insert point to correct the nasal underfold, the nasal fold, and the same insertion point. But sometimes I use the cannula also in the lips when I need only volume. Look, this is a 27 gauge cannula, just to get a little volume of lips. In Italy, in Europe, we do a lot of lip enlargement. We have a big request from lips infiltration. Just 1 cc of hyaluronic acid and the it's a, but if you these lips, we have already volume. I need only the correction. This is secondary lips infiltration. It's not my patient. So in this case, I need needle. Need needle just to correct in precise point the volume deficit for the projection, and finally, to accompany the lips in the face, I make 2 infiltration outside of the lip red mucosa. And like this is a mustache infiltration, upper and lower. Look, is 1 dot point just to enhance the angle of the lips. And after I move up in linear threading, a conjunction from the zygomatic to the lips in this way, subcutaneous, very, very subcutaneous. And that is my infiltration rate. You see the plane of infiltration, linear threading, very few amount of product in this way. So in this way, in this manner, the lips is very huge in the face, very harmonic. That is the line that I would like to emphasize. And then we move to the nasolabial fold, another important area. This is juvenile in nasolabial fold. I inject with needle 0.8 of Pcl, and the correction before and after is pretty good. The insertion point, it will be this. You see in the dark blue is very deep. I use cannula. because when I go deep for the natural hair fold, it's mandatory to use cannula to evitate pain and intravascular injection. When I move more superficial, I can use cannula, but I can use also the needle. So the vectoring is this, from down to upper inner part, and finally I do crisscross too. So I inject in this way, to have a crisscross infiltration. And that is the correction for this. Look, before the fossa canina is deep, empty, after is full. The filler is not so subdermal, is very, very deep in the bone, in the premaxilla. That is before and after. Another tricky problem that we have in this area, in the lower part of nasolabial fold, is the nasolabial sulcus. Is due to the muscle, risorius muscle. The contraction of this muscle do this kind of wrinkles, and the correction will be this, in my experience, very soft hyaluronic acid, very superficial, in multiple dots, 1, 2, 3, 4, 5 dots, non-confluent, perpendicular in the sulcus. That is the before and after. That is the wrinkles due to the hypertrophy, hypertony of risorius muscle. Here, after. Another point of view, 3/4, before and after. And then we move to the chin, lower. So we see the lips, nasolabial fold, and now we see the chin. The chin, this lady, is oval shape, square shape, fatty lipodystrophy under the chin, and after filler injection, no liposuction, no treatment of fat, only engagement of the chin with filler. How do you manage this? Usually I do 1, 2, 3, 4 dots with needle deep in the chin bone to make elongation of the chin. It's very simple, little painful, but it's very simple with good result. I don't inject in the muscle. And then to complete, I inject with cannula, more superficial, with one insertion point in this point, in the middle, in the right side and the left side, with cannula I inject. So finally, the injection, it will be a sandwich technique, deep and superficial in 2 layers. And that is the correction. Look, this lady, before and after chin injection correction. And again, another lady from Russia, Ukraine, before and after the infiltration of the chin and the pre-jowl sulcus and post-jowl. That is the correction, only filler. Another square face from Polish. Look, before and after. This harmonic, big face, we don't have to use a lot of filler, just a little bit filler to have a uniformity of the jawline and correction. And this lady from Cuba, that is the correction, starting uniformity with moderate flaccidity. It's very good cases because the skin, dark skin, is very elastic, very thick. So it's good patient for a good result. The injection I manage in 2 insertion points, in the preauricular area and in the pre-jowl sulcus, to inject in the post-jowl and pre-jowl. And finally, that is the result that we like. before and after the jawline redefinition, 1.5 per side of calcium hydroxylapatite. Very good result, very stable for 1 year, only 1 year. But then I can manage, I can repeat the treatment as I prefer. Another patient from Russia, square face, jawline, U-deformity, and I have a little video how I treat this patient with PCL-based filler. Usually in the pre-jowl, I use needle. Why? Because in this area, the retaining ligaments is so strong, it's difficult to manage with cannula. I prefer to use needle, so I will be more precise in my infiltration. And in the post-jowl, I usually use 22 gauge cannula. This cannula is stiff cannula, is cannula from TSK. TSK from Japan is very good cannula, and I can manage my infiltration from up to down. If the patient has photoaging, I can have this kind of problem of fibrosis under the skin, but after that is very simple technique to have good result and very natural. And I show you some cases of jawline redefinition, the correction U-deformity. Look, this lady, moderate aging, 46 years old, before the planning of treatment, pre-jowl, post-jowl, nasolabial fold. I treat all the area, the lower third, and that is the lady. It's like a lifting. In fact, I call liquid face lifting, before and after treatment with filler. Only filler, no botulinum toxin, no threads, only filler. That is what we can have with the right filler, a good filler like PCL or calcium hydroxylapatite. And look, this lady, before moderate flaccidity, the planning, no infiltration, why after treatment, and look, this lady after 1 year, 2 years, she changed the color of the hair, but the jawline is very stable because the polycaprolatone filler, PCL based filler is very long lasting, 2-3 years. And look, this lady before 3 years later, she changed a look. He have a little volume due to the weight fat, but the jawline is very stable after my first treatment. And look, this lady from Indonesia, we move to the nose and chin. This patient have some problem of the nose shape and chin. Usually, in fact, the main issue for this lady, I think it was she called to me to correct the nose, but I looked at the chin, the mental tubercle, there isn't. So my correction starting from the nose, but I inject a lot of PCL-based filler in the chin to have elongation, to have more view shape of the face, no oval and square face. Before square face, after that I will have more view shape face, and that is before and immediately after treatment from this patient from Surabaya. And this is before and soon after. Look, it's completely changed just with 2 vials of filler in the chin and in the nose. That is my correction. And look, this lady from Indonesia, I treated in the upper third because she has the problem, she has the face have a pear face, like a pear. So she has deficit con asymmetry of the face in the right side, less empty, more empty than the left side. But the deficit is in this area, in the nasojugal sulcus, nasolabial fold, in the highbrow and temporal fossa, and that is before and after treatment with filler. This patient I treated in Jakarta with only with hyaluronic acid. She was very pretty correction for me. And another patient from Indonesia, look, this lady, the face, she has a poor involution of fat in the nasojugal sulcus and nasolabial fold, and the highbrow filler. So the planning was this: nasolabial fold, nasojugal fold, and the highbrow to have elevation before and after correction of the eyebrow, the round shape of the cheekbone, because we have empty in this area, very tired face, and nasolabial fold to correction. And finally, why not? I inject also in the chin, because if you notice in the profile, she has a deficit of chin elongation, and before and after infiltration in the chin. So these two cases, last cases that I show you today, come from Indonesia, and I treated the full face treatment. And all these areas are published in this book, I repeat, in Italian, in English, and in Russia. And I think it's coming also the translation from Indonesian people. Thank you for staying with me. And now is the moment to talk, okay?
Okay, thank you very much, Professor Luca. This is very nice presentations, and your book, I see it's very complete. Yeah, everybody can learn about fillers from this. So, to all participants, doctors, please, you can write down your questions in the question box, and Professor Luca will discuss about your questions. Again, yeah, this is about the filler. Yeah, I saw in your last PowerPoint, it's about the tired face. There are lots of Asian people looks like that because of tired face. How many filler do we use to correct the under eye hollow about tired face? What do you suggest, Professor Luca?
I suggest less is more is better. So I inject with needle just 2-3 dots here in the nasolabial fold near the bone layer to make pyramidal infiltration in this part to make elongation. That is the best option. Anyway, I can treat also now. I treat another product, the combination bionut lift with cannula from the arcus marginalis with cannula, or the upper part of border of the lower margin of bone with filler and free HA in combination. Free HA more superficial, the filler deep. So I have the sustainment, the tightening, and I have also skin improvement. That is bionut lift, so-called from Filmed.
Okay, yeah, thank you very much. And then, yeah, we're still waiting for questions from the audience. Now about talking about the nasolabial fold. So your technique, which technique is better if we do injection filler for nasolabial fold?
Yeah.
Whether is it using the cannule or the blunt cannule, or we use a sharp needle? Could you please explain, or in which age?
Yes.
In elderly, like, well, and then when
I understand,
younger
good
people.
question, because the nasolabial fold it's a more simple injection that when the first injection we do when we start our career in the nasal fold. Like blepharoplasty for surgeon is the first surgery that a young surgeon perform. But finally, there are very tricky area. The blepharoplasty is very difficult to have a natural blepharoplasty. The infiltration of nasal fold too is very difficult. You have to study the patient. Now, more and more, I inject deeper in the bone, in the fossa canina with cannula. I use 25 gauge cannula, 38 centimeter short. The access point is in the middle part of nasolabial fold to evade the artery. So I stay in the medium to the artery. So I don't cross the artery. I inject the cannula from here, and I work all the filler in the premaxilla.
Okay.
One time ago, I used needle, very perpendicular in this part, but it's very painful. So it's safe but painful. So I don't use anymore. I use cannula, very good product, very good infiltration.
Okay, yeah. Okay, and then if we go down to the marionette line and the sagging face when it comes to elderly people, how do you do the filler, the technique filler for the marionette lines? I saw also in your
yes,
presentation.
I show you, I use sometimes very deep, I use cannula from the prejowl, but it's not so easy to make correction of marionette filler. The marionette, I use the needle, short needle, 6 millimeter, perpendicular to the skin, multiple dot, perpendicular in a pyramidal way, but not in the bone, just under the skin to make elevation.
Okay, okay, thank you. Now we've got questions from the doctors, from the audience. Wait.
Yeah.
Wait, this one is... many patients have a broad nose lobe, yeah, especially in Asian people, and wide nostril. How to manage this kind of patients? What do you think, Professor Luca?
I have a beautiful video that I don't show you. I use nose augmentation with PCL-based filler. Usually my favorite techniques is with cannula. The access point is in the tip of the nose, and I go very deep. It's very, very fantastic projection, but the secret is not to overcorrect, never overcorrected. So to reduce the infiltration, the complication, to reduce the complication rate, I use 1 syringe, 1 ml per time, no more. So if I need more product, I have to wait 2, 3 months, 4 months, and then I go another vials. So the correction is step by step. It's a gradual approach for the final correction.
Okay, yeah. Now, the next question is from Dr. Fenty.
Hi,
Prof. Yep.
Yeah, if you want, I have a video. I can show you a video.
Oh, you want to share your video?
No.
Later. Okay. Now, we've come to another question. Now from Dr. Fenty. Do you have any complications so far using the PCL-based filler?
No, I never have complication. One time I see a lot of complication because I work for the company. So around the world, I see a lot of complication, but the complication is due to the overcorrection. Some doctors that use too much product in a wrong way. Because the product is safe, you have to use in the very right way, few amount per site. The infiltration will be very delicate. We never overcorrect, and I never have. Only one time I have one problem because I do a big dilution of product. I put too much lidocaine inside, and it is not good, because when you inject the product very diluted, you make alteration of product. The viscosity of the product will be off. So the company study a lot of time to have a stable viscosity and fluidity of product. If you make a dilution, you can have some accumulating, as you say. You can have some non-regular infiltration, some cluster, and that is, you can have some nodules, something like that. So I suggest to use the product natural, in very soft infiltration way.
Okay, Professor Luca, we've got another questions. Now from Dr. Mehta. Hello, Professor Luca. Is there any possibilities to shape a bulbous nose to a more pointy nose using filler? Yeah, again, this is about nose, yeah.
Yes, understand. So the answer is this, is not only aesthetic medicine. Some cases we need surgery. When I have a bulbous nose, big nose, I have to reduce the nose, to reduce the cartilages. I cannot put more product to have more projection, because it's very difficult to have steep projection. Also, if I have tension nose is the nose with very tension, the ligaments is so strong, you have to cut the dorsum, you have to cut the hump, you have to cut the ligaments. If not, there is no result. So it's important to have a good result to make selection of patients. Not all patients are good for rhino filler. Some patients are good, but not all.
Okay, yeah, okay. So we have to consider, yeah, whether this patient can be done with filler or suggest for surgery. Yeah. Okay. Yeah. For all the participants, is there still any questions for Professor Luca? Yeah. I'm still waiting. If there's anybody who wants to give questions, we're still talking about fillers, and this is Professor Luca have shared so many techniques about lip filler, about nasolabial fold, and also about the chin. Oh yeah, Professor Luca, I saw in your presentation about the chin filler. That's very nice. How many mils the volume for the filler do you give for the patients to make the beautiful chin?
And the average is 1 to 2 ml. 1 to 2, no more.
1 to 2.
It depends. 1 ml for sure. Sometimes I need 2 ml if I have elongation in the jowl. So 1 in the middle and 1 is in the jowl. That is my experience.
Okay.
But you have to consider that calcium hydroxylapatite and PCL-based filler, the average is different from hyaluronic acid. If I use 1 ml of hyaluronic acid, 1 ml of PCL or calcium hydroxylapatite, I need to have the same result. Is almost 1.8 hyaluronic acid. So the average is different from PCL and calcium hydroxylapatite in comparison with hyaluronic, because hyaluronic acid doesn't give good result enlargement.
Okay. Yeah, thank you, Professor Luca. We've got another questions. Now this one from Dr. Fenty. Wait. Wait. How to manage the adverse sorry. How to manage the adverse effect if it happens, because PCL-based filler cannot be dissolved with hyaluronidase. This is about using a PCL-based filler, and this cannot dissolve with hyaluronidase. If there is any adverse effect, how do we manage this?
Yes, that is the problem. So for that, you have to inject a very safe way, you cannot you never overcorrect, but you can make dilution of product and spread the product. After, you can use corticosteroid or collagenase to reduce the reaction to the product, because the product gives stimulation of collagen. So you can use corticosteroid and collagenase to reduce the reaction. But be aware to inject the filler in the right quantity, no more.
Okay, thank you, Professor Luca. We've got another questions. Now, this one from Dr. Gita. How to use filler under eye bag in case if there is fat bulging under the eye? Please, Professor Luca.
Can you repeat, please?
Yes. So the question is, how do we give filler for under eye bag? And this case, the patient has fat bulging under the eye. So the under the eye has fat bulging. Can we treat with filler, and how do the technique for this?
Yes, I think you mentioned that you would want to know the bulging here, the malar fat pad.
Yes.
Malar fat pad, yes, sometimes I use filler. This is two ways for the correction, or inject very deep to make a distension of the area. Is with strong filler in the deep area. I manage the new volumization of this area, and that is good. But also in this area, if you put too much product, superficial, is not good, because you can make obstruction of lymphatic, because this area is very sensible to the lymphatic stay. So if you put the filler in the superficial area, you block the lymphatic, and the result will be worse. Another way, I can inject a little bit the transition of the skin to make sustention. So mostly I inject deep in the bone in the pyramidal way to make tension only.
Okay, thank you. And then we've got another questions. Could we use thread with PCL together? So the doctors ask, combining threads and PCL, PCL filler.
Yes, sure. Not in the same section. Usually, if I have the already volume in the face, I use before threads and after 1 month, 2 months filler to refine the sulcus and the deep area. If the patient is very empty, like in Italy, we have a very lipodystrophic patient, I use before PCL filler, and then after 1 month, I use threads to make repositioning. That is.
Okay, and what kind of thread do you suggest if we combine this, floating or anchoring thread?
Anchoring threads, I prefer.
Okay, okay. The next questions. This one comes from Dr. Els. Wait. Wait. Could we use thread? Hello, doc. How to fill the cheek area? Can you explain the technique? So this means for the malar area, injection filler.
So the entry point will be 2, usually with cannula, 25, 23 gauge. One entry point in the arcus marginalis here, and the other entry point is here down in the lower part of the face. I make a funny technique, superficial and lower in a multiple layer. It's very good correction and stable.
Okay, yeah. Now we have another questions. This one is, how about injection for men? I mean about the dose. How many mils fillers for men, and where is the injection spot? Could you please explain?
Yes, for men, I usually use calcium hydroxylapatite. It's very strong. It's indicated for men or PCL. and I use 2-3 ml for the face restoring in one section, no more. Why? Because this product gives you inflammation by stimulation. If you use more than 3 ml per time, you can have a little edema after treatment. So I prefer to use 3 ml and then I stop and I visit the patient after 2-3 months, and they can refine in different layer with hyaluronic acid, more superficial. So my touch up will be with hyaluronic acid, because I show you, I use usually combination of treatment, depends from the area, very deep with this kind of filler, more superficial with hyaluronic acid.
Okay, yeah, okay. I think there's no more questions from the question box. Yeah, maybe Professor Luca, you may give some conclusion or some take-home message for the doctors, especially for the technique of fillers that you have mentioned. Please, Dr. Luca.
So it's very important if you are not surgeon to make a training in a cadaver lab, because when you inject, you have to know very well the anatomy, where you are injecting, how you are injecting, but where you are injecting. So the surgeon doctor are lucky, because they all the day open the skin and look under and see a lot of problem. But dermatologist, ENT, and other doctor, is very important to have training in a cadaver lab. Then pay attention in some patient with other filler, pay attention in patient with post-surgical anatomy, because after some kind of anatomy, there is a completely subverted anatomy. So pay attention when you have one patient with surgery to take care. And then last but not the least, less is more. I prefer to inject a little bit and then again after another time.
Okay. Yeah, thank you very much, Professor Luca. We have a great discussion about filler technique, yeah, and from Professor Luca. I hope you always in a good health, Professor Luca. Stay healthy, stay safe, and success always for Professor Luca. And to everybody here, thank you. Yeah, thank you. You all have joined this session today, this session 7 until session 8. And we will meet again in the session 9 on the 14th of January. So everybody, stay safe, stay healthy. This is the end of our session in virtual Iswam today. Take care all. Bye-bye. Thank you, Professor Luca.
Dancing